In recognition of National Psoriasis Awareness Month, welcome to part 1 of our webinar series, More Than Skin Deep, Clinician Education to Improve the Diagnosis and Therapeutic Management of Psoriasis in Female Patients. To receive continuing education credit for this activity, you must take the pre and post test. If you have not taken the pre-test, you are viewing this webinar live. You will find the pre-test link in your reminder email, and the post-test link will be sent to you after the webinar. If you are viewing this webinar on demand, both the pre and post-test links can be found below this video. In the webinar dashboard, you should see a chat box that you can use to answer questions throughout the webinar, which our faculty will answer at the end of the webinar. In 4 weeks, you will receive an email from ARHP's Education Department with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you have learned during this webinar into your work. Completing the pre and post test as well as this follow-up evaluation helps ARHP ensure we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce our faculty, Dr. Anthony Fernandez and Sandy Worthington. Dr. Anthony Fernandez serves as Associate Medical Director in the Center for Continuing Education and Director of Medical Dermatology at the Cleveland Clinic, and as an Assistant Professor of Clinical Medicine with the Cleveland Clinic Lerner College of Medicine. He earned his medical degree from the University of Illinois College of Medicine at Chicago and his PhD in developmental biology, molecular biology from the University of Illinois at Chicago. He is a member of the Dermatology Resident Education Committee and earned the Teacher of the Year Award 3 years in a row for his contributions to the dermatopathology and clinical dermatology residency program. Sandy Worthington. Sandy has focused her career on reproductive health education. She has educated over 1,000 nurses to become women's health nurse practitioners. Sandy earned both her undergraduate and graduate degrees from the University of Pennsylvania School of Nursing. She was the chair of the WHNP Test Committee of the National Certification Corporation and served on the NCC Board of Directors. She has also served on the Board of Directors of the Association of Reproductive Health Professionals and the Alliance of Nurses for Healthy Environments. She has authored numerous publications and received many awards, including the year 2000 NPWH NP of the Year. We're thrilled to have them with us today, and without further ado, I'll hand it over to Dr. Fernandez.
Thank you, Chantel. Before we begin, I would just like to point out that this continuing medical education activity has been made possible by a grant from Novartis, and we are thankful to them. The ARHP Planning Committee members are listed here, and most of these individuals have no disclosures. I want to point out that I do speaking, research, and serve as a consultant for AbbVie, and I've been a speaker for Celgene, and both of these companies do have medications that are used to treat patients with psoriasis. Our learning objectives for this afternoon are first to summarize the epidemiology of psoriasis among women in the United States, to describe the various subtypes of psoriasis and how to make a diagnosis of psoriasis, as well as to discuss treatment options for women with psoriasis. And finally, to apply counseling and patient education techniques that will support both sexual and psychosocial health in women who have psoriasis. Let's begin with an overview of psoriasis. Psoriasis is a very common chronic immune-mediated disease that predominantly affects the skin but can affect multiple organs, and we'll talk more about that with time. The etiology is not known. However, it is thought to be a multifactorial process that involves both genetic susceptibility in some patients as well as immune dysfunction, and that entire process is thought to be triggered by a variety of environmental triggers. Psoriasis is a heterogeneous disease, and that's very important to understand. There are numerous subtypes of psoriasis, and we'll talk about those, and different subtypes will present with cutaneous lesions that have a variety of morphologies, anatomic distributions, and the different subtypes can vary in terms of overall severity and in terms of their disease course. Classically, when most individuals and healthcare providers think about psoriasis, they will visualize well-circumscribed red plaques that have overlying thick silvery white scale, and that is the most common subtype of psoriasis. Importantly, psoriasis has a significant negative impact on patients' quality of life. It can be associated with numerous physical symptoms, but also emotional symptoms, and create a tremendous social burden on affected patients. And it's also incurable at this time, although we are lucky to have a variety of treatments that can be very effective at treating even patients with the most severe of presentations. Psoriasis, as we mentioned, is extremely common. It in fact affects about 2 to 3% of the world's population, including 2 to 3% of the US population, and this translates into approximately 7.5 million Americans with psoriasis at any given time. The overall prevalence of psoriasis is somewhere between 1.5 and 5%, and it is thought to be on the rise, and the prevalence is highest among Caucasians, with approximately 3.6 prevalence in this population. And with this number of patients affected by disease, you can imagine that it has a tremendous burden on the U.S. healthcare system. And it's estimated that the costs of treating psoriasis are around $112 billion per year. The disease does affect men and women equally. There is not a predominant sex that is affected, and it most commonly is seen in adults, but can be seen in all ages, from the youngest of children to the oldest of adults. In general, the onset begins in early adulthood, with a mean age of onset somewhere between 15 to 20 years of age. But there is a second peak of onset in individuals between the ages of 55 and 60 years old. So we do see patients in middle age who have developed disease for the first time and require treatment. A significant number of women will develop psoriasis during their reproductive years, as you can see by the most common onset age range, which is in early adulthood. And luckily, the majority of patients, upwards of about 80%, will have mild to moderate disease, whereas only about 20% will have disease that is categorized in the moderate to severe range. And that is based on body surface area involvement of the skin. As we mentioned, the etiology of psoriasis is not completely understood, but it is thought to be multifactorial in nature. There are specific genes that some individuals have that will predispose them to psoriasis, and this is underscored by the fact that if you have a family history of psoriasis, we know that you would be at somewhat of an increased risk for developing the disease as well. We do strongly believe that environmental triggers are usually necessary for the onset of psoriasis, even in the setting of a strong genetic predisposition. And there are a variety of environmental triggers that have been described as starting the disease process, anything from simple stress that we all experience, and certainly use of tobacco, alcohol, obesity, and a number of other factors. Pertinent to women, hormonal changes can definitely influence onset and severity of psoriasis. Although we do not know the Etiology of Psoriasis in detail, we have learned a lot about the pathophysiology of this disease from an immunologic standpoint over the past 30 years. And we now understand that in the background of some genetic predisposition and some environmental external trigger, there is activation of the innate immune system cells, and these include keratinocytes and numerous monocytes and T cells, and these become activated and will generate numerous pro-inflammatory cytokines, which then in turn activate myeloid dendritic cells. Activated myeloid dendritic cells will then engage cells of the adaptive immune system, namely Th1 cells via production of interleukin-12 and Th17 cells via interleukin-23. And these cells become activated and then will activate keratinocytes to produce antimicrobial peptides and additional pro-inflammatory cytokines that act back on cells of the innate immune system, such that we create this loop of inflammation that as of now, we do not know how to turn off in terms of curing the disease. With that said, this understanding has allowed us to create a number of targeted genes or medicines that have allowed us to control even the most severe cases of psoriasis today. And these include medications that we'll talk about later, such as TNF-alpha inhibitors, interleukin-12/23 inhibitors, and interleukin-17 inhibitors. So what happens in the setting of this immunologic dysregulation is that we see a rash on the skin. And when we look at skin that is affected by psoriasis, we can see changes at all the different levels that are somewhat specific. On the left-hand side of this slide, we see normal skin. This very top layer where you see this basket weave thin layer of tissue is called the stratum corneum. And then underneath this, we see this dense cellular layer that is known as the epidermis. And then underneath the epidermis is the dermis, where most of the immune system cells reside. In psoriasis, the stratum corneum is significantly thickened. And that visually is demonstrated as the thick silvery scale that you will see in individuals with psoriasis. Additionally, the epidermis is significantly thickened and more cellular, and this is because in psoriasis, these cells, mostly keratinocytes, will reproduce at a very rapid rate, where they'll divide every 3 to 4 days, whereas in normal skin, it typically takes about 28 to 30 days for these cells to divide. And that thickness causes those raised red plaques that you see in patients with psoriasis. And the immunologic component can be seen here in the dermis with all of these inflammatory cells that under normal conditions are not present. There are a number of psoriasis subtypes that are important for any healthcare practitioner to be able to recognize. And as we mentioned, the most common subtype is plaque psoriasis, and this accounts for about 80 to 90% of all psoriasis cases. It does present with very well demarcated erythematous plaques with this overlying thick silvery gray scale, and this most commonly affects extensor surfaces such as the elbows, the knees, the scalp, but can affect any area of the body. Guttate psoriasis typically will present with an acute onset of small erythematous papules all over the body. And classically, guttate psoriasis starts abruptly in children or adolescents following a streptococcal infection. In children, this will sometimes resolve with time without the need for prolonged treatment. However, when it occurs in adults, this is less so the case and will more often persist. Inverse psoriasis, in some ways, is the opposite of plaque psoriasis. Whereas plaque psoriasis most commonly affects extensor surfaces, inverse psoriasis affects flexural surfaces, the axillary vaults, so under the arms, the inframammary areas, the groin. And it's still very well demarcated and erythematous, but it tends to lack that thick silvery scale that's typical of plaque psoriasis, mainly because these are areas of the body that are moist because skin is usually touching skin. Pustular psoriasis presents with plaques, but also pustules, so pus bumps, and this is a subtype of psoriasis that is uncommon, but importantly can be seriously, when it is precipitated, can require the patient to be hospitalized, and is well known to be triggered when systemic glucocorticoids are used to treat psoriasis and tapered somewhat rapidly. Erythrodermic psoriasis implies that a patient has at least 90% of their body surface area covered in psoriasis. This is uncommon, but we see it, and it can cause severe itching and pain to the skin, as well as consumption of significant amounts of protein because the skin cells are dividing rapidly all over the body. SIBO psoriasis affects the scalp and presents not only with plaques but with somewhat greasy scales, so that the clinician has some difficulty distinguishing between whether it is psoriasis or seborrheic dermatitis. However, psoriasis elsewhere on the body can help to narrow that diagnosis. And then nail psoriasis is also common, and the nails can be affected with a number of patterns. You can have these yellowish spots called oil spots, which implies that the nail bed is separated from the nail plate. You can have pitting or divots throughout the nail, and that's due to involvement of inflammation in the proximal nail fold where the stem cells of the nail are made. And you can have thickened nails. So nail dystrophy is very common in the setting of psoriasis. The female genital areas can definitely be associated or affected by psoriasis. This most commonly is seen in the setting of inverse psoriasis, again, where areas like the inframammary folds and the groin are affected. Most commonly in the genital area, it affects the labia majora. It will not affect the mucous membranes. And the lesions also here typically will present with well-demarcated erythematous plaques, and again, usually without scaling because of the moist skin in these areas. But as you can see here, sometimes the presentation doesn't necessarily reflect a very well demarcation, and you can get some areas of scaling. As you can imagine, psoriasis in these areas is extremely uncomfortable. The most common characteristic or symptom patients will complain of is itching, but also they can have pain. And this is often misdiagnosed as some other condition, such as a sexually transmitted disease or an allergic reaction to some lotion that the patient is using in the area. And it profoundly can have a negative effect on patients' quality of life. It can be associated with significant psychologic distress, even depression, and it can adversely affect sexual health. In one study of almost 500 patients with genital psoriasis, it's probably no surprise that the patients with genital lesions reported a significantly worse quality of life than those without, as well as a much higher level of sexual distress and dysfunction, particularly in women when the genital skin is affected. Aside from itching, there are a number of symptoms that patients may complain of when they have psoriasis on the skin, and this can be regardless of the anatomic location that is affected. So in addition to itching, painful skin is one of the most common symptoms that individuals will have. They will complain that their skin gets very dry and has cracks, especially when the palms and soles are involved. They can develop fissures. These can be extremely painful. The scalp can be scaly, and this usually results in significant itching. And then, as we mentioned, the nails can often be affected, and this can lead to pain when they use their hands for even activities of daily living. So how do we make a diagnosis of psoriasis? Typically, we can, based on a medical history and a physical examination taking into account the morphology of the skin lesions the patient has, as well as the anatomic locations that are involved, make a diagnosis clinically. With that said, even plaque psoriasis, the most common subtype, is associated with a relatively long list of conditions that can mimic psoriasis, and just a few of them are listed here. But even more important entities such as lupus or secondary syphilis are in the differential diagnosis. So if something seems off in the history, in the physical examination, or if the patient is diagnosed with psoriasis but doesn't respond to treatment appropriately, then we need to consider alternative diagnoses. And in these situations, in addition to other laboratory examinations we may do, this is where a skin biopsy will be helpful. And as you saw earlier, we, in the setting of psoriasis, can see changes that should make us either confident about that diagnosis or consider other possible diagnoses. Once we make a diagnosis of psoriasis, then we want to assess the severity of the disease. And this will kind of lay the groundwork for how aggressive we will be in treating the patient. First of all, we look at the skin and assess the body surface area that is involved with psoriatic lesions. The National Psoriasis Foundation has published guidelines for defining mild, moderate, and severe disease. Mild disease is defined as having less than 3% of the entire body surface area affected with psoriasis. And you can think of 1% of your body surface area as being the area of a single palm, including the fingers. So 3 palms worth of psoriasis or less constitutes mild disease. Moderate disease is defined as between 3 to 10% body surface area, and severe disease is anything greater than 10% of a patient's body surface area involved. The other thing that's important in assessing a patient with psoriasis, once you make that diagnosis, is any comorbidities, and educating the patient, most importantly, that psoriasis is not just a rash. Psoriasis, we now understand, especially in its moderate to severe forms, is a systemic inflammatory disease. And it is important to control that systemic inflammation because it can lead to a number of comorbid diseases. Some of the important ones are mentioned here. Psoriatic arthritis is arguably the most common comorbid disease that occurs in patients with psoriasis. It is a seronegative inflammatory arthritis, so we do not have a blood test that can help diagnose psoriasis or psoriatic arthritis. And it will affect upwards of 30% of all patients with psoriasis. And importantly, most patients will develop the skin disease before they develop the joint disease. And psoriatic arthritis has variable presentation, but it is commonly a peripheral arthritis affecting the fingers, as seen in this picture. And patients can also present with findings such as dactylitis, which implies that an entire digit is swollen because of synovitis and inflammation affecting multiple interphalangeal joints in a single digit. But also very important, over about the past 15 years, we have clearly learned that patients with moderate to severe psoriasis are at increased risk for developing cardiovascular disease, and this includes increased risk of myocardial infarction, strokes, peripheral vascular disease. And in fact, studies have shown that patients with moderate to severe psoriasis have about a 5-year lower lifespan than patients without psoriasis, and this is largely thought to be due to the increased risk of cardiovascular disease. But other diseases are clearly associated with psoriasis, including increased risk of inflammatory bowel disease, both Crohn's disease and ulcerative colitis, metabolic syndrome, non-alcoholic fatty liver disease, COPD, depression, which has been shown to affect upwards of about 60% of all patients with psoriasis, and obstructive sleep apnea, to name a few. So when we think about how to treat a patient with psoriasis, we do want to take into account the overall skin involvement, any comorbidities the patient has at that time, but we also have to take into account other factors to assess the overall severity and how aggressive we need to be to treat patients. And this includes anatomic locations, not only the genital areas, but also the face, which, as you can imagine, even if you have mild disease or less than 3%, can cause significant emotional distress and depression, and also the palms and soles. This is very important anatomic locations in patients who have isolated psoriasis just on the palms and soles. If we just calculated their body surface area, that's going to be low, but this can affect patients to the point where they cannot perform activities at work or even their activities of daily living. So we have to assess the impact on quality of life, and then, of course, if a patient has psoriatic arthritis, that will immediately put us in a separate category of treatment. So what are these treatment options? Treatments can include topical medicines, phototherapy, and either systemic therapy that includes pills or injectable or infused medicines. And we do need to take into account the different pregnancy categories when treating women who either are pregnant or who are planned to get pregnant, or young women in general. Topical therapies are one of the most common types of medicines used. They are definitely first-line treatment for patients with mild disease, and we will often use them as adjunct treatment in patients with moderate to severe disease. These can be used intermittently when patients flare over long periods of time, and clearly topical glucocorticoids or corticosteroids are the cornerstone of psoriasis treatment. There are many different strengths and types of corticosteroids, and there are a number of things we will consider in choosing how strong of a medication to use and the vehicle, an ointment versus a cream, etc. On areas where the skin is relatively thin, such as the face, the breast, the genital areas, we favor low-potency corticosteroids, whereas for the trunk and extremities, we'll favor mid or high-potency steroids. Most corticosteroids are pregnancy category C, so we do try to minimize use of these in pregnant patients with psoriasis, but they can be used if needed. And then we have to take into account other potential adverse events, such as thinning of the skin with prolonged use, and we do want to avoid patients putting these all over the body for extended periods of time, because we can suppress the HPA axis where they're getting significant absorption, similar to if they were taking oral prednisone. With very strong corticosteroids, class 1, we do want to limit their regular use to only about 2 to 4 weeks, but we'll often use them intermittently after that. Phototherapy is another effective, relatively safe treatment option for patients. Again, it's first line for patients with mild disease and even moderate disease, and it can be used alone or in combination with other therapies in patients with all severities. There are a number of different types of phototherapy. The most common we use now is narrowband UVB. Psoralen plus UVA was used in the past and can be very effective. However, not only its pregnancy category, but its downstream risk of developing skin cancers has made this a very unusual therapy to use, given all the other effective therapies we have right now. It does lack the systemic toxicities of other immunosuppressive medicines, so it can be used during pregnancy. It does locally immunosuppress the skin, and that's part of why it works. Importantly, phototherapy does not control systemic inflammation, so we do not think it's going to have an effect in protecting the patient from cardiovascular disease down the road. And it requires frequent office visits, since the schedules are usually that the patient will receive this 2 to 3 times a week. And then, of course, because it is UV light, the more of this you receive, the more risk there is for skin cancers. Traditional oral medications include methotrexate, cyclosporin, acitretin, and one of the newer ones is apremilast. Methotrexate is the most commonly prescribed systemic therapy for psoriasis. It's been used for over 50 years. It's a pill that's usually taken on a single day of the week. It has some common adverse events, but most patients tolerate this well, and importantly, this is pregnancy category X. You simply cannot give this to any woman who is pregnant or who plans on becoming pregnant. Cyclosporin can work very rapidly for moderate to severe psoriasis and can be very effective. It is dosed based on ideal body weight. We do have to monitor patients' renal function when they're on this medicine, and it is pregnancy category C. Acitretin is generally less effective than other systemic treatment options we have. However, it is a pretty safe medication when you need to use it. It does not immunosuppress the patient, but this is another medicine that is category X for patients who are pregnant, and in fact it has such a long half-life that we do not even consider this in anyone who really has any chance of becoming pregnant, regardless of whether they tell us they have no intentions of ever becoming pregnant or not. Apremilast is a newer medication, is a phosphodiesterase 4 inhibitor that's approved for moderate to severe psoriasis, and it's also approved for psoriatic arthritis. It's pregnancy category C, and common adverse events include gastrointestinal issues, as well as some degree of increased risk of depression in patients. And then the biologic therapies, which first became available to us in 2004, are really what we use the most in our patients with moderate to severe psoriasis, and they have revolutionized our ability to control patients with severe disease. And these are categorized as agents that target tumor necrosis factor alpha, or anti-TNF agents. These include etanercept, infliximab, and adalimumab. There is one agent that targets interleukin 12 and 23 called ustekinumab. There are now 3 interleukin 17 inhibitors, secukinumab, ixekizumab, and brodalumab, and just within the past 2 months, a single anti-interleukin 23 agent named guselkumab. Most of these are given by subcutaneous injection. Infliximab is given via an IV infusion, and the medications that have been out for some time do have data available and safety data concerning use in women of reproductive age or pregnant women. And most of these are category B, so in many ways thought to be safer than the traditional medicines we've had. For some of the newer medicines, we do not yet have available data, but we expect to have this with time. There are new treat-to-target goals in patients with psoriasis. These were published just earlier this year by a panel of psoriasis experts, and it is recommended that we try to get the patient controlled to the point that they have less than 1% body surface area of psoriasis at 3 months, so less than 1 palm's worth of psoriasis, and that we maintain this response during the maintenance therapy period. However, it was agreed that an acceptable response is anywhere where the patient has overall mild involvement of psoriasis. And this mild degree of cutaneous disease has been associated with minimal amounts of systemic inflammation and therefore decreased risk of comorbid disease development, importantly cardiovascular disease. And with that, I'll now turn it over to Sandy.
Thank you. So I want to cover some additional consideration for managing psoriasis in women. And we've already talked about the psychological and mental health impairment, but I can't reiterate enough. Psoriasis is associated with a high rate of psychiatric comorbidity, which often goes unrecognized. And the prevalence of depression and anxiety in patients with psoriasis is significantly higher than that observed in the general population. And in fact, patients with psoriasis disclose a higher rate of suicidal ideation than other patients. Recent work has identified that psychological worry and anxiety occur in at least one-third of the patients with psoriasis, and that psychological interpersonal difficulties impact all aspects of the patient's daily life. Moreover, feeling of embarrassment and unattractiveness, as well as altered body image, contribute to the psychological distress. In a study that examined health-related quality of life issues in patients with psoriasis, women reported nearly twice the mean number of mentally unhealthy days compared with men with psoriasis. And there's a growing body of literature that supports some link between major depressive disorders and inflammation. Research has shown that patients with psoriasis have a reduction in their quality of life comparable to or worse than patients with other chronic diseases such as cancer, arthritis, ischemic heart disease, diabetes, and depression. It's well established that patients with psoriasis feel extremely stigmatized by their disease, and this contributes to their low esteem and ability to develop relationships. And a number of factors contribute to diminished quality of life among patients with psoriasis, including the chronic nature of the disease, lack of control over unexpected outbreaks, discussing skin conditions, feeling of shame and embarrassment with skin exposure, and social avoidance behavior, and limitations in daily activities, occupational functioning, and sexual functioning. A recent U.S. non-interventional study evaluated 101 patients' experience of living with psoriasis, including symptoms, treatments, impact on daily lives. The study design consisted of narrative interviews conducted at baseline and within 16 weeks. The 7 impact areas evaluated were emotional, social, family, professional, physical, educational, and sexual. In interviews, patients with moderate to severe psoriasis indicated symptoms, ranked symptoms according to the level of bother, and indicated areas of their life affected by psoriasis. The most bothersome symptoms, as one would expect, were itching, scratching, flaking, and scaling, and skin pain. Impact areas most frequently reported were emotional and social, again underscoring the tremendous toll that this disease takes on aspects of individuals' lives in addition to just the physical component. And these are just a few of the select verbatim statements from patients who participated in the study. And you can see here, I'm very ashamed of the way I look, just like people looking at me. The flaking causes a lot of embarrassment, and a lot of times it's just easier to stay home than go out. You feel like you're a leper. No one wants to get next to you. No one wants to touch you. That's all I've ever felt since I got psoriasis, was frustrated. Frustrated that there wasn't an answer, there wasn't a solution. There's no one I knew had it. No one my age had it. I guess the things that go hand in hand is ugliness, the confidence killer of it, the stares, and other people's questions. I think it kind of molded me into this really insecure person. The depression affects my whole family, not just me. I cry a lot, and my daughter sees that, and I don't like her seeing that. And I personally had a client a little while ago who came in for a reproductive exam just before she was going off to college. And she did have psoriasis on her face and her scalp. And she said to me, well, most of my friends want to stand out in a crowd. All I want is to be invisible, which made me feel pretty sad. We already talked a little bit about sexual function, but again, it's been recognized for some time that psoriasis can have a negative impact on sexuality and relationship in a substantial number of patients. Scientific evidence shows that patients with psoriasis have a higher risk of sexual dysfunction compared with the general population. The risk factors associated with sexual dysfunction in psoriasis are disease severity, female gender, age, and psoriatic arthritis. And as one can imagine, genital involvement also significantly affects sexual function. In an observational study of 354 patients, 38 had current genital involvement and 63% had current and/or prior history of genital involvement. 43% reported dyspareunia, 32 had worsening of genital psoriasis after intercourse, and 43% had a decreased frequency of intercourse. When evaluating patients for psoriasis, obtaining a thorough sexual history is very important, and providing support to patients to find best approaches to discuss health and skincare with their partners is also essential. And I know that sometimes it's difficult for healthcare providers in a busy practice to discuss sexual function, but it's so important to let clients open up about their inadequacies and fears around sex and their relationship with their sexual partner. So some things we can recommend to patients are condom use during intercourse reduces potential skin discomfort and helps avoid skin-to-skin contact. And to cleanse the affected area before sex and reapply medication after sex. And psoriasis in any form is not contagious. And that's a message you really want to give your clients, and you want your clients to give to their family and friends. You want to encourage to bring partners to office visits for enhanced education, counseling, and reassurance. And also consider complementary therapies, referrals to trusted sexuality educators, counselors, and therapists based on the patient's and the partner's needs and their priorities. Next, I just want to talk a little bit about dietary and nutrition considerations. While many options exist for treatments of psoriasis, nutrition is a therapeutic component that should not be overlooked. Dietary modifications, including a gluten-free diet and a low-calorie diet, have been shown to induce statistically significant improvement in clinical psoriasis. In several studies, including a large-scale study of over 12,000 patients, a correlation between psoriasis and celiac disease has been established. Based on this association, a reasonable hypothesis is that a gluten-free diet, which should improve celiac disease, will lead to improvement in psoriasis. And several studies have indicated that implementation of low-calorie diet versus a free diet is associated with trends in improvement of psoriasis. And so basically, a heart health diet is what you want to recommend to your clients. One that has grains, low-fat dairy, low-fat meats, fruits and vegetables, fish, and things that are high in omega-3s. In addition to various diets, multiple oral and topical nutritional supplements have been studied in the treatment of psoriasis. For instance, vitamin A therapy is best utilized when complemented by additional treatments. Both oral and topical preparations have proven effective in treating psoriasis. Low levels of vitamin D correlate with more severe psoriasis. As with vitamin A, oral and topical formulations for vitamin D are known to be beneficial in treating psoriasis. Most commonly, vitamin D is used topically, and particularly in combination with topical corticosteroids, topical vitamin D analogs. And another potential useful dietary addition is a combination of supplemental selenium, coenzyme Q10, and vitamin E, which has been shown to improve severe forms of psoriasis. And there is some support for the use of omega-3 fatty acids The dietary factor that psoriasis most negatively impacts psoriasis is alcohol. And a beta analysis of 15 case-controlled studies showed a statistically significant association between psoriasis and alcohol consumption across the number of stratified analysis. We've already talked about the effect of tobacco use as a trigger. And along with nutrition and consideration, I'd also like to just interject lifestyle of how much exercise can help to improve. Okay, next I want to cover a little bit about makeup considerations for patients with psoriasis. Moisturize, moisturize, moisturize. Excuse me, I'm sorry, I got ahead of myself. Let me go, sorry. Frequent moisturizing is a cornerstone of skincare for patients with psoriasis. Patients should moisturize at least twice daily all over after applying any topical medication to help improve penetration and efficacy. Moisturizing more often may be helpful to thicker plaques. Moisturize immediately after bathing within 1 to 2 minutes to trap in the moisture. Ceramide-based moisturizers are excellent, and over-the-counter options include CeraVe, and every product they make has a ceramide, including ointments, creams, lotions, sunscreens, cleansers, and they have an anti-itch lotion that can be very helpful for patients with itchy skin symptoms. Cetaphil Restore Derm line, Aveeno Eczema line, and Eucerin Eczema Relief line are also helpful. And Vaseline can be helpful. It's a thick ointment and may be most helpful at bedtime if too greasy for the daytime, along with Aquaphor. With either of these, you might want to apply the Vaseline and then put a plastic wrap over it, and then put on your night clothes so that you don't get it all over, and it holds the moisture in. In general, in terms of efficacy, first line is ointments, and then creams, and then lotions. And patients should be advised to use gentle skin cleansers and avoid antibacterials, excessive cleansing, or fragranced products. And some recommended products are CeraVe, Cetaphil, Restore Derm, Aveeno, and Dove Bar Soap. Sunlight may help improve psoriasis plaques, so sun exposure can be helpful, but only if the patient doesn't get sunburn. Caution is advised, as sunburn can flare psoriasis, since this disease commonly flares in sites of trauma. Just another reminder to always use sunscreen. And now moving on to makeup considerations for your clients. Between 50 and 80% of patients with psoriasis develop lesions on their scalp. This presentation can range from slight scaling to thick crusted plaques that cover the entire scalp. Because of the visible nature of scalp psoriasis, this can be an especially frustrating manifestation of the disease and result in significant emotional distress. And once again, I got ahead of so I will go back. I'm going to finish this out though. Special shampoos available for patients with scalp psoriasis can contain ingredients designed to reduce inflammation and soften and loosen scales on the scalp so they can be washed away. Two of the main types of psoriasis shampoo are coal tar shampoo and medicated shampoo. The active ingredients in the latter may be corticosteroids or salicylic acid. And it's important to discuss hair washing frequencies and hair styling practices with your patients with scalp psoriasis. Patients need to be educated about the implications of hair dyes and perms, since these chemicals in hair dyes and perms can sometimes irritate and often worsen scalp psoriasis and cause allergic reactions. So we recommend that you do a testing of the solution on a small area of the skin prior to full use. And patients with type of psoriasis may want to learn more about various hairstyling techniques to help camouflage their psoriasis, such as extensions and braids, and also learning how to use accessories to cover up, such as hats or scarves. And now I want to go back to makeup considerations. Okay, treating women with psoriasis involves more than just managing their type of psoriasis. Consideration of cosmetic and aesthetic aspects is a vital part of helping female patients cope with their disease and be able to work and look their best. While many clinicians may not feel comfortable or have the time to get into conversations with their patients about cosmetics, having a fundamental knowledge about that what might work for patients regarding makeup is recommended. Patients should start with a cleanser formulated for sensitive skins. Additional tips is to counsel patients on including the use of fragrance-free primer, choose the correct foundation formula and avoid powders, do a patch test first to check for sensitivity and effectiveness, and apply makeup with a gentle dabbing motion and keep coverage simple. And consider consultation with a professional makeup artist for application tips and tricks. And the website that is listed here refers to additional information for patients on choosing and applying foundation. Okay. As we know, different ethnicities have different textures of hair: fine, straight, coarse, curly. And steroids solution are often preferred by Caucasians, Asians, Hispanic patients. Steroid oils are often preferred by African American patients. Ointments, possibly creams and lotions, typically are avoided in the scalp for psoriasis, but may be used if patients prefer them. Ketoconazole may also be added to the regimen to treat SIBO psoriasis. And counsel patients to shampoo with gentle massaging motion with the fingertips to loosen the scalp. And steroid ointment treatments overnight to wash, prior to washing will help loosen the scales prior to shampooing the next day. And certainly when they do that, you want to make sure that they wear a shower cap to bed. Now, when it comes to skin care, makeup, and hair care, women may need to try different products before finding things that work best for them. Encourage your patients to be patient. If something's not working, try something else. And no one therapy works for everyone, and therapies may not consistently work over time. We also want to mention racial and ethnic considerations. Underreporting and selection bias may contribute to observed differences in the prevalence of psoriasis in minority populations. Racial and ethnic disparities in access to a dermatologist have been reported in the United States, and the likelihood of having underdiagnosed psoriasis was higher among African Americans in a national study analyzing NHANES data from 2003 to 2004. In darker skin types, psoriasis may have overlapping features with other papulosquamous disorders and have less conspicuous erythema, thus presenting diagnostic challenges. There are key nuances in clinical presentation of psoriasis and skin color, including less conspicuous redness. In fact, it may appear more violet or hyperpigmented. There's a nuance of post-inflammatory hypo or hyperpigmentation, and potential increased areas of involvement, or the body surface area is larger at the initial presentation. In African Americans, the impact of hair texture, styling, and practices of washing frequency should also be considered. Some nuances for treatment are phototherapy in darker skin types should include a brief discussion about increased pigmentation in exposed areas. Selection of topical treatment regime that is compatible with hair care practices and cultural practices. And traditional Asian healing practices such as cupping, coining, and the use of herbal remedies are examples of the factors that may be relevant to the clinical presentation of psoriasis in some patients. The use of some herbal medication can potentially be associated with drug-to-drug interaction. So don't forget to ask your patients, what are you currently using for your skin condition? And there is a whole group of dermatologists who have formed an organization called Skin of Color Society. And you can certainly go online and find continuing education offerings that are specific to the area of skin of color. And lastly, complementary and alternative medicine for psoriasis. Complementary and an alternative medicine, or CAM, is a general category of products and practices that are not part of the standard care offered by most medical providers. CAM use in common patients with psoriasis, an example are seen on this slide, like the dietary supplements such as fish oil supplements, vitamin D, vitamin B12, herbal therapies such as tea tree oil, dead sea salts, coconut oil, turmeric, and aloe vera. And exercise. An example here is they're showing yoga, and certainly yoga has been known to reduce stress, and acupuncture. And it's important for clinicians to treat patients with psoriasis to be aware of the potential benefits as well as side effects associated with these alternative therapies to allow for informed discussions with your patients. And I'd now like to turn it back over to Dr. Fernandez for the case study.
Thank you, Sandy. In the interest of time, I will run through this case relatively quickly, but this is an example of a patient and how we would go through the treatment process. So in this case, we have a 42-year-old Caucasian woman, and she presents with more than a 1-year history of worsening thick pink scaly plaques, not only on her back, abdomen, thighs, and arms, but also moist red plaques in an inverse pattern, so areas under the breast, in the axillary vaults, and in the intertriginous folds of the groin. And she complains not only of itching, but is also distressed by the fact that the rash is worsening and spreading. Clinically, after examining the patient, you make a diagnosis of moderate to severe psoriasis. However, just to confirm the diagnosis, a 4mm punch biopsies are taken from some of the intertriginous plaques in the inframammary areas. as well as from one of the lesions on the back. When the patient leaves the office, you initially treat her. I can get this slide to turn. Here we go. You initially treat her with clobetasol during the week for all areas except for the body folds where the skin is relatively thin, and then use more in a limited fashion Monday through Wednesday in the body folds, just to minimize further thinning of the skin and other adverse events. In several days, however, you get the biopsy results back. They confirm psoriasis, and given the patient has moderate to severe disease, you recognize that this warrants treatment with a systemic medication, and methotrexate plus folic acid is initiated with narrowband UVB phototherapy given as adjunct therapy. You see her back in 3 to 6 months, and she has not cleared, so you plan to transition her to a biologic medication. And as you know from this presentation, we have a number of excellent options to choose from. And the patient's insurance typically requires failure of medications like methotrexate prior to approval for biologic therapy, and so that is why we prescribed her the methotrexate initially. And so with that, we'll move on to the question and answer session.
Okay. Thank you, Tony and Sandy, for the excellent presentation. Now let's answer some questions. So first question we received, do other autoimmune disorders increase the risk of psoriasis?
There are at least immune-mediated conditions that we know are associated with increased risk of psoriasis. The main category of disease really being inflammatory bowel disease, but also rheumatoid arthritis. There are certainly series of patients with conditions like lupus or other autoimmune diseases that also will have psoriasis, but we don't really think of most patients with autoimmune diseases as having a terribly increased risk of developing psoriasis.
Okay, and second question, does losing weight in obese patients affect psoriasis?
Yes. Losing weight has definitely been shown to be a way to treat psoriasis. In fact, there are numerous cohorts that have been published of patients with moderate to severe psoriasis who will get gastric banding surgery or similar interventions, lose significant amounts of weight, and those reports have shown that there's a significant improvement in the severity of the patient's psoriasis as a group with those types of interventions when controlling for all other medications.
Okay, and we received 2 more questions that we can try to quickly get through. How common is a mix of psoriasis types versus one type?
Relatively common. So clearly plaque psoriasis is far and away the most common subtype. But we will see patients who have some degree of an inverse pattern of psoriasis, like the patient in the case study that we just went through. Relatively common. Erythrodermic psoriasis is often triggered by some other event in a patient who already has known plaque psoriasis. Guttate psoriasis, those lesions, although they're relatively small, with time they can coalesce and form plaques, so it appears that the patient has a combination of both guttate lesions and the typical plaque psoriasis. So it's relatively common, and we don't really think much about those combinations in terms of how we treat the patient. I think the important thing in terms of the subtypes is just to recognize that you may be looking at psoriasis as opposed to some other condition.
Okay. If we did not get to your questions, if you could please email education@arhp.org, and we will send you an answer to your questions. I want to thank Tony and Sandy again for joining us today for the wonderful presentation. Before you exit this webinar, please note the following. Be sure to visit arhp.org to view 2 clinical minutes and register for the second webinar in this series, which will be next Thursday, August 31st at 2 p.m. on psoriasis across the female lifespan. As a reminder, you will receive an email from ARHP's Education Department containing a link to the post-test survey. Your CME and RCE certificate will be generated at the end of the survey. Be sure to print the certificate before closing the internet browser. If you have any questions, please email us at education@arhp.org. Thank you for taking the time to view this webinar. We hope that you will take part in another live and on-demand activities hosted by ARHP. Thank you.
We just want to close with the key takeaway points that are chronic relapsing and remitting inflammatory skin disease that is multifactorial in origin and associated with considerable physical and emotional distress and impaired quality of life. Psoriasis affects approximately 7.5 million Americans, including a significant number of women during reproductive years. And numerous comorbidities associated with psoriasis include cardiovascular disease, metabolic syndrome, irritable bowel disease, cancer, obesity, liver disease, and depression. Approximately 80% of patients with psoriasis have mild to moderate disease and can be treated with topical agents. Phototherapy recommended for patients with moderate to severe psoriasis and may be used in combination with other therapies. Systemic therapies play important roles in treatments of psoriasis and require consideration of pregnancy category in women of childbearing potential. And it's essential to discuss medications to avoid with psoriasis patients who plan to become pregnant. And here are just a few helpful resources that you might want to tap into for further information. And we'd like to thank you very much. And here are some additional resources through ARHP. We have the webinar that's going to happen next week, August 31st, that is going to be covering specific areas of psoriasis through the woman's lifespan. And we have clinic minutes available on demand, but go to www.arhp.org. We also have educational slide decks on http://core.arhp.org. And we'd like to thank you very much.
Thank you.